and I'm coming all the way from. So as sir has just mentioned, so my aim here in the next 40 minutes or so is to talk about how do we, as pathologists, how do we approach gastric biopsies, particularly in the context of gastritis. So gastritis, as we all know, is inflammation of the gastric mucosa, and which should be histologically confirmed. Many a times these patients are asymptomatic, and endoscopic biopsies may not be telling us much. So really, who are these patients who would have these endoscopic upper GI endoscopic biopsies? Essentially now, they don't necessarily have to have too many symptoms. Even a vague abdominal pain is sufficient to have the scoped down. And what we have found is that, honestly, I know I've got the gastroenterologist here, but there is not too much of a correlation between what they see as gastritis and what we see as gastritis. But nevertheless, gastric biopsies still continue to be a bulk of our department's workload. And at this point, I just want to encourage every pathologist to have this very close, a relationship with the gastroenterologist, because it's extremely important to have that cooperation between both the pathologist and the gastroenterologist in order to make sure that we are effectively managing the patients. So what can we expect from clinicians? Again, I'm aware of the gastroenterologist here, clinical history. And many times we would like to know if the patients are on PPI or on non-steroidals. We are seeing changes, but we haven't got that information. We'd like to know the endoscopic biopsy findings. Many a time it's erythema, edema, but no more than that. But it would be nice to see whether there was thinning of the mucosa. And Sydney protocol is what is recommended. I will come to that in a bit towards in the talk. And ideally, we should be having biopsies from different sites. That's two from the body, and two from the antrum, and one from the gastric fistula, all labeled in different cassettes, or sorry, in different containers. So really, we would like the antrum and the fistula coming together as one, if that is okay, and the fundus, the body biopsy coming together as in another bottle. And for sure, if there are other additional findings, then that should be biopsied as well. So let's look at, there's a good place to start. What's normal? So many a times, when I have the residents next to me, I'll ask them, so where is this biopsy from? And they will look at me and say, stomach. But then, stomach is different, and it's important, different part, and it's important to know what's what in each part of the stomach. So whenever you see these specialized cells, as the chief cells and the parietal cells, what we are thinking about is the oxyntic region, which can be the fundus or the body. So the chief cells are these basophilic cells, and they are important for pepsinogen 1 and gastric lipase secretion. Whereas these very pink cells, or the eosinophilic cells, the eosinophilic granular cells, they are the oxyntic cells, and they are responsible for the intrinsic factor production and the anthers, that's the HCl. Coming to the antral fragment, antral area, we don't have the specialized glands, but rather we have a lot of mucus secreting glands, and they are rich in pepsinogen 2. And additionally, there are also the neuroendocrine G cells. I forgot to mention that there are the ECL cells in the oxyntic region. So these are the basic differences that one should be aware of. So here I am going to give you a very practical approach on how to make the diagnosis of gastritis. And it is a pattern-based approach. I've tried to include cases as well, so I really would like a little bit of interaction also. So topography. This is very important. Like I was telling you, I would ask the residents, where is the biopsy from? So where's the biopsy from? So they would look and tell me, there is no point in saying gastric mucosa, because I need to know where it is from. Even irrespective of whether the pathologist, the endoscopic has told me that this is body biopsy or it's an antral biopsy, one should be absolutely clear whether you're looking at the body or whether you're looking at the antrum, because there are certain pathologies which is antral dominant and those which are corpus dominant. It's extremely important to understand the difference, because that helps you to ascertain the etiology. So let's start with the most common, which is the chronic gastritis. So normally you will see some mononuclear cells, maybe about 5 lymphocytes, plasma cells per high pass field. And then sometimes you may see them even between the foveolae. So you really need to go into a higher power. Just make sure that you're looking at, especially when it's very subtle, to ensure that there is a mild increase in chronic inflammatory cells. So once you've understood that there is mild chronic inflammation, then it's very important to just say whether this is mild, moderate, or severe. Try and categorize it as best as possible. And just a word of caution, try and grade it away from those lymphoid follicles that one might often encounter. So you're trying to say whether what sort of is a gastritis at first, and then try to quantify it as best. Now, it's another way to look at it is that is it top heavy or is it bottom heavy? Now, these are clues to a diagnosis. If you're seeing it as top heavy, then that certainly helps to understand what the etiology is. Whereas if you're looking at bottom heavy, which means it is really long-standing, that again helps to approves towards a certain diagnosis. So this is a good way to start. So one, you look at the biopsy and think, are there features of chronic gastritis? I've just told you how to make that understanding. Then the next thing to look is, are there neutrophils? If so, how much? Is there Helicobacter? Now this is mandatory. Every gastric biopsy should have a word to say whether Helicobacter is present or not. Then following that, you look to see whether there's glandular atrophy, is there intestinal metaplasia? And then following that, understand where the biopsy is from, the site of the biopsy, because this topography is very important. Is it involving the antrum or the corpus, or is it involving both? Is it a pangastritis? Additionally, look for other features. Don't just stop there. Look to see whether there is, and are there any histiocytic aggregates? Is there any foveolar hyperplasia, any viral intrusions, anything else that might, is there any foreign material? Anything else should not be missed. And then use ancillary tests appropriately and then understand how to make the interpretation of those ancillary tests. So we'll start with the first case. Here, this is a 45-year-old who had presented with dyspepsia, bloating, and the upper GI endoscopy was done, which showed erythema and erythema, and it was there both in the antrum and body, and the biopsies were taken. They did not really have any further opinion on that. This is what we got. Any thoughts? I think from even at this power, you would say, and even from such a distance, you will say, it certainly looks a little bit more blue, isn't it? So that blue should alert us to the fact that there is a mild increase in inflammatory cells. So going to, and then I think additionally, you can see that there are some small lymphoid aggregates as well. And then this is yet another power, another view to show us that there are these lymphoid aggregates also. So is there chronic gastritis? Probably, yes, isn't it? Not probably, there is. Now, I just don't stop at the, from a distance, go look into the higher power. And here you will find that there is also, in addition to the chronic inflammatory cells that we can see here, there are neutrophils. So that implies activity. So it's very important to say whether this activity is mild, moderate, or severe. So you will look for activity, that is the neutrophils in the lamina propria, within the crypts as what we can see here. And then if there's any within the lumen also, which are the crypt abscesses. So always quantify the activity. And then additionally, if you went back to that first image, you would have seen that these are actually two sides. Here we've got some specialized glands. So that means this is the body or the corpus or fundus. And here we've got no specialized glands, suggesting that this is the antrum. So this tells me that we've got an inflammation that is affecting both. And further on, there were some focal areas which also showed intestinal metaplasia. And also there was thinning of the mucosa, which suggested that there could have been a little bit of atrophy. On higher power, I'm not sure whether this is clear. There were a few Helicobacter-like organisms also. So biopsy site, we understood it was both antrum and body. Well, so is there chronic gastritis? Yes. Was it mild, moderate, or severe? Moderate, at least. Were there neutrophils? Yes. Was it mild, moderate, or severe? Moderate, maybe. Was there Helicobacter? Yes, you have to believe me on that one. So glandular atrophy? Yes, there was. And intestinal metaplasia? Yes. Was there dysplasia? No. Malignancy? Did you see anything else? No. Do we need any special test? What would you need? But you saw the Helicobacter. Oh, I saw the Helicobacter. Okay, you can do GIMSA, and that can just confirm. So really, this was a chronic active pangastritis, with mild atrophy. There was focal intestinal metaplasia. It was H. pylori associated. Now let's come back to the history. See, you are the only person who could have told the clinician that this was H. pylori associated chronic active gastritis. This is all that they told us, that there was erythema, and that's why they took some biopsy. So I just want you to emphasize your important role in this multidisciplinary team, how you contribute towards patient care. You don't get much, but you can give out a lot more. So as we all know, this was a landmark paper that was that had come back, and which clearly has taken a long way from 1984 to where we are now, where H. pylori is a type 1 carcinogen. So H. pylori, you will on the GeneSat, this was the same case, by the way, and here there were a few Helicobacter-like organisms. So this is a H. pylori, which they are seen as small curved, curvilinear spiral organisms, and occasionally you might see them as small coccoid forms also. So they do have, I don't have time to go into how the special adaptive mechanism is, but then there is the surface mucus, and there is the bicarbonate, which keeps the epithelial integrity. Now, H. pylori comes and it has its way of surviving in that very acidic environment, but nevertheless, and in addition, it disrupts that very friendly or that protective environment that the mucosa is used to. So that's how the H. pylori creates the inflammation, or perpetuates the inflammation from moving from a chronic to chronic active, and then it progresses to ulcerations, atrophy, and intestinal metaplasia, dysplasia, malignancy. So somebody might ask me, should I say there is one, there is two, there is plenty, there's dense colonization? What do you think? Is one good enough? Is one H. pylori good enough? Yes. Okay, so there is no need for you to say how much, but probably it would be relevant in the context of epidemiological studies. I must admit that when I see dense colonization, I just get a bit excited, and I say there is dense colonization in the report. Now, there are non-invasive diagnostic tests like the CLO, the urea breath test. There's a fecal antigen test, and also serology can be used, but they are not entirely sensitive. So H. pylori, as we have already said, it's chronic active. Try and grade it. Topography is important, and look always look for the complications, which is the atrophy and the intestinal metaplasia, because they do increase the risk for gastric malignancy. Now, when I talk about gastric malignancy, is it just carcinoma? No, it's also the lymphoma. So what do you think this is? Does this look like the H. pylori that we saw? Why? It's a little more longer, and it's more spiral, isn't it? So this is Helicobacter helminthi. So it's special stains, GeneSat can be used, Geminis can be used, and IHCs can be used. So do we need to do it in all? Not when it's obviously there, but certainly when you've got that milieu is there. It looks severe, it looks chronic, if there is activity, but you are not seeing H. pylori. You just know it's got to be there, but you're not seeing it, then for sure you must do a special stains. Or if there's extensive metaplasia, you're not going to see the H. pylori, you must do the special stains. Or if there is, in the context of follow-up biopsies where you might not see H. pylori, you must do the ancillary tests. Now, what if you saw H. pylori versus helminthi? The treatment is the same. Of course, H. helminthi is much more rarer. Now, coming to this, now when you use, I just want to emphasize that you've got a case like this. This is a recent case where there was severe chronic active gastritis. It was H. pylori associated, but also very focally, there was this focus of dysplasia. So always look for other additional features also. Don't just stop with just having given one diagnosis. So coming to other infectious gastritis, there is, if you saw granulomas, for sure you must think of tuberculosis, syphilis, depending on the clinical context also, histoplasmosis, fungi, etc. We'll just quickly move to the next case. This was a 69-year-old who was known to have a low-grade non-Hodgkin's and with bone marrow involvement post-chemotherapy. And she then recently presented with a low-grade fever, yellowish sputum, increased frequency of stools, no abdominal pain or vomiting. But nevertheless, she had an upper and a lower GI endoscopy. And what they had found was extensive erosion, also patchy, not extensive. Extensive meaning it was there, patchily, erosion, and maybe some superficial ulceration. So this was a gastric biopsy. What do you think? Increased LP cellularity? Maybe. This is a higher power. There are lots of there are eosinophils for sure. There are some plasma cells and then a few neutrophils. So we look at mild chronic, maybe a little active also. So there's mild chronic, there's a few neutrophils. H. pylori was not seen. We didn't see any atrophy or IM, and there was no dysplasia. Additionally, do you see anything? Some viral inclusion such as this. And then also it was interesting to see that there were many glandular lumina which had these small dots. Any thoughts? So a GIMSA was done. And the GIMSA did not highlight any Helicobacter, but rather highlighted these basophilic bodies, which is a cryptosporidium. So here we had chronic active gastritis, but in this case, there was co-infection of both CMV as well as cryptosporidiosis. So again, the use of ancillary tests, it's not always just to look for Helicobacter. It can help you for other pathogens also. Coming to the next case, this is a 35-year-old who had undergone a renal transplantation in 2018. Last year, this time, she had a varicella infection, and then she was doing okay up until the end of last year when she had worsening of her renal functions. A renal biopsy was done in November, and that had shown acute tubular injury, but there was no morphological evidence of active rejection. In December last year, she continued to have severe anemia. Peripheral smear showed microcytic hypochromic anemia. And then she was referred to AIIMS Kochi because of her worsening graft function. And on admission, she was found to have jaundice, deranged LFTs, viral panel was negative. And then because of the abdominal pain, and then she went on to developing dysphagia, she underwent an upper GI endoscopy. They saw a few erosions. So this is what we had seen. So when you look at this biopsy, there doesn't seem like there's a lot of inflammation, isn't it? Maybe at the most mild. And maybe the occasional neutrophils were also there. There was no atrophy, but there were these inclusions for sure. And these inclusions very much suggesting that this was the IHC that was done for CMV. Again, there were not that many, but you must make sure that you don't miss it because it was important in this, for treatment. So this patient went on to having a fecal biopsy after this because she just did not do well. A fecal biopsy done a couple of days later found that she had a large proliferative mass, and on biopsy, we found that it was a post-transplant lymphoproliferative disorder. Unfortunately, she expired a week later. So I just want you to know that we as pathologists do actually stand at a pivotal site. Now, we could not have afforded to miss that CMV that was there, but again, there were other features that had to be addressed also. So coming to CMV gastritis, common in the immunocompromised and also occasionally in children. Now, very important, endoscopically, it may be normal or it may be frank ulceration. Now, where do you look for it? You must look for these viral inclusions in the stromal cells, endothelial cells, and also occasionally they could be in the epithelial cells. They can be, you may not see much inflammation like what we had just seen in our case, or it could be just severe active gastritis. They may be accompanied by numerous eosinophils also. So that's CMV gastritis. So I hope by now you have seen we've moved beyond Helicobacter to occasional other pathogens also, and the use of ancillary tests like GIMSA, which can be useful in other scenarios. Coming to the next case, this is a 48-year-old who had a liver transplant. Autoimmune etiology was thought as the underlying cause. And she was okay up until the 15th day when she developed hematemesis and melena. So there have been view of the hematemesis. She had an upper GI endoscopy, which showed a 5-centimeter gastric ulcer and which had the stigmata of a recent bleed. And that was in the lesser curvature. She was given pantoprazole and also ganciclovir because of possible CMV. But she had hematemesis, continued to have. And this time a repeat endoscopy showed that the ulcer has enlarged, and therefore biopsy was taken from that ulcer base. This is what we saw. So here there's no chronic, it's just ulceration, just frank ulcers. And within that ulcer, just frank ulceration, just a lot of purulent inflammatory debris, lot of acute tissue destruction. And there were these very broad, thin-walled aseptate hyphae, which is the mucor. So this was gastric mucormycosis. So by the time I told them that this was gastric mucormycosis, she had another massive bleed. It was recovered, necessitating intubation. And then an emergency endoscopy was, again, was performed to try and somehow control this arterial bleed. But unfortunately, she succumbed. So this was to show other pathogens also, and especially in the context of post-transplant. So this was actually a case from a series that we had published. And what I can say is that the diagnosis is usually delayed due to non-specific symptoms. And early endoscopy is endoscopy with biopsy is the key to diagnosis. And these endoscopic features can mimic ischemic injuries. There could be ulceration, which are sharply demarcated, associated with necrosis, thrombosis of the adjacent vasculature, and you may have this black eschar. So, but nevertheless, you are the only person who can give out the diagnosis as a pathologist. So, which PCR can also be done, which can add to the diagnostic yield. So I'll move on to the next part of my talk. In between, you can see a little bit of Kochi also. So coming to non-infectious gastritis. So this is a 10-year-old who had atopic eczema. She was diagnosed to have UC about 6 years ago, and now she presented with rectal bleeding. She was having really very bad symptoms for at least 4 to 6 times a day with blood, crampy abdominal pain. Appetite was okay, and she had come to us for further management. So colonoscopy, our pediatric gastroenterologist told me that this was just severe bad pancreatitis, as you would expect in a flare of UC, and the upper GI endoscopy was normal. So this is the, I'm not showing the colonoscopy biopsies, but this is what we saw on these were the normal looking biopsies that we had received. So I'm sure on low power, nothing much to see, isn't it? You can see that they are both specialized, non-specialized. So he usually takes from different sites. But then on higher power, there were, in children, you can see these lymphoid aggregates, but there was a subtle increase in the chronic inflammatory cells. Mild, of course, the threshold should be much higher when it comes to children, but there was a very subtle increase in the chronic inflammatory cells. And then there were these sort of aggregates like this also, which showed that around certain crypts that there were some lymphocytes, histiocytes, maybe the occasional neutrophils here, and almost maybe destroying a crypt, and maybe 1 or 2 histiocytes coming through there. And then for just having seen that much, that prompted us to take further deeper levels, and that revealed that there were definite areas of histiocytic aggregates such as this, and such as this, and such as this, almost suggesting that these are multiple ill-formed granulomas. So this was maybe another area where the crypt is surrounded by some lymphocytes, histiocytes, and there were the occasional neutrophils there. And here you've got a few histiocytic aggregates, selective collections there. So what are we looking at? So here we've got, what's that inflammation? At best, mild, isn't it? Neutrophils, maybe just focal. There was no helicobacter, there was no atrophy or IM. And the topography, yes, it was antrum, but there was a little bit in the body also. For sure, we saw something else, isn't it? There were these focally enhanced gastritis, and there were ill-formed granulomas. Do you need to do any special stains? Yes, you must do GIMSA, just to make sure that you have not missed a helicobacter. So what are we looking at? Here was a child, a 10-year-old, who was labeled to have UC, but the upper GI endoscopy, which was completely normal, has actually suggested that probably this is not UC, but probably this is Crohn's disease. And that was because of the concomitant inflammation in the upper GI biopsies and the presence of the ill-formed granulomas. So Crohn's associated gastritis, usually you don't see much inflammation, or there could be just very patchy acute inflammation with pititis or abscesses. Focally enhanced gastritis, for those who are not familiar with it, it's actually a small collection of lymphocytes and histiocytes that's around or associated with the foveolae and the glands, and often with and you might see a few neutrophils also. But in severe cases, you can have a severe chronic inflammation. You might see a few epithelioid histiocytes. So any such appearances should prompt you to take some further deeper levels, and that can reveal some small ill-formed granulomas, which is a clue to the diagnosis. Now, granulomas can be infectious, not infectious, which we have already discussed, or I have just mentioned, but non-infectious sarcoid is the other thing to also keep in mind, foreign material also. So moving to the next part, which is the gastropathies. Now, gastropathy is when you do not have a lot of inflammation, but there are other changes which suggest that there is a pathology in the gastric biopsies. So gastropathies are drug-related, drug-induced, or alcohol or radiation. That's the reactive gastropathy. You can have the reflux, which is the bile acid reflux gastropathy, or the chemical, the non-steroidal gastropathy. So how do we understand this? So when you look at these biopsies, they, at a distance, they don't seem to have a lot of inflammation. I mean, they don't look blue. But what actually helps us to understand is this very characteristic corkscrewing that you see of the fovea. So really, there are 4 points to this. So you see the foveolar hyperplasia, and that's because of this chemical noxae, which increases the turnover of the gastric epithelium, and that's what causes this very marked foveolar hyperplasia. Mild is not, you should see a good corkscrewing before you consider them. And then there's usually numerous congested capillaries, and that's because of the pro-inflammatory cytokines. There's edema of the lamina propria, usually a paucity of inflammatory cells or very mild, minimal chronic inflammatory cells. And also there would be a mild thickening of the muscularis mucosae. Often you will see these vertically splayed smooth muscle fibers. So these are the features of chronic gastropathy. They're usually asymptomatic, but they can be ulcerated also. Another very common entity that we see, or a finding that we see, is that many of these parietal cells are quietly mildly dilated, and they can have apical snouting. And so you would comment that there is parietal cell hypertrophy, and often associated with PPI therapy-related changes. So let's look at another case. Here, this was way back in 2022, this patient, a 60-year-old male, presented to us with abdominal pain, which is poorly localized, and heartburn, abdominal bloating, constipation. And this was the upper GI endoscopy. So here, they saw that the fundus was normal, body had some erythema, antrum also showed some streaks of erythema, pylorus was normal, D2 was normal. So biopsy was taken from the body and antrum, and essentially erythema, nothing more than that. So this is what we have seen here. Have a good look. So just keep in mind the same approach, chronic inflammation. Do you think there is? For sure, isn't it? Okay, so keep this in mind. There is definitely an increase in chronic inflammation. Now, before we start about chronic inflammation, the site of the biopsy. Specialized or non-specialized? We are not seeing any specialized cells here. Okay, so that's something to just keep in mind. So always a good place to start topography. Okay, and then additionally, you're seeing there is chronic inflammation. We've got some lymphoid aggregates. Maybe this falls into the bottom heavy because we're not seeing so much of them on top, but rather it's more towards the bottom. We are not seeing any specialized glands. There is, if you look, the mucosa is quite thinned out, and there are patchy areas of intestinal metaplasia. Now, this was actually, in addition to that, you can see that there is an increase in chronic inflammatory cells. There are no specialized glands, although this was labeled as body. Here, this again emphasizes that, that there is atrophy. And that is again to show the same. So chronic gastritis, yes, this was at least moderate. Were there neutrophils? Didn't see. Okay, so it's just still chronic. There was no H. pylori. There was atrophy. There was intestinal metaplasia, no dysplasia or malignancy. So this is what we had got. So this was gastric body, but there was no parietal cell. And therefore, one has to consider that this is antralization of the gastric body. There was no Helicobacter, chronic atrophic gastritis with intestinal metaplasia, antralization of the gastric body, autoimmune gastritis is definitely considered. Antrum was normal. So I just want to just I had shown this picture earlier. all the findings that we had seen, but additionally, there were these nests such as this, which I think you can clearly see here, a few more in here. But if I were to go back, if you notice, there are some small nests such as this in here coming down. So therefore, a synaptophysin was done, which highlights that there is a ECL cell hyperplasia also. So as you can see, we've got both linear as well as nodular ECL cell hyperplasia. So because we had raised the possibility of autoimmune gastritis, labs, they had tested the serology and found that IF was positive, antiparietal cell antibody was also positive, serum gastrin was very high, vitamin B12 was low, and therefore all confirming that this is autoimmune gastritis with pernicious anemia. Now remember, what was the endoscopic findings? And I'm completely aware that we have gastroenterologists here, but remember the endoscopic findings did not tell us too much, but we understood it from our end here. Patient was started on vitamin B12 correction, and then subsequently chromogranin levels were also found to be high. So autoimmune gastritis is relatively rare. Clinical signs include hypo or achlorhydria, hypergastrinemia, and that's because we have destruction of the parietal cells, and therefore there's a reflux reaction to cause hypergastrinemia. There's low pepsinogen, pepsinogen 1, pepsinogen 2 ratio. B12 is deficient. The antiparietal cell antibodies and IF antibodies are present, and often it coexists with other autoimmune diseases. Now, there is this molecular mimicry with H. pylori. The H. pylori antigen and the hydrogen potassium ATPase antigen. So the T cells recognize, the T cells of one recognize the other, and that's why H. pylori can give a similar picture as an autoimmune gastritis. The progression to adenocarcinoma is also high, and as we have seen, there's also a progression to carcinoid tumors. So autoimmune gastritis in early stages might be difficult to pick up, but certainly in a stage such as ours, where there was diffuse lymphoplasmacytic infiltrate, it was bottom heavy, there was atrophy, there was increased thickness of the foveolar component, pseudopyloric metaplasia, that's the antralization of the gastric body, and increasing intestinal metaplasia, all are sufficient to call this as autoimmune gastritis, and therefore you should ask for the serology. End stage such as this, where there's marked destruction, you cannot recognize this as being corpus. There's marked foveolar hyperplasia, and there's extensive pseudopyloric metaplasia, pancreatic metaplasia, intestinal metaplasia, and all of this suggests that this is end stage. And I think that on the endoscopy, you will see very thin mucosa with the vessels being seen clearly. So a few words on this enterochromatin cell hyperplasia. And as I had suggested, it's achlorhydria. There's no acid, so that prompts the G cells to secrete excess gastrin, which leads to the histamines producing ECL cell hyperplasia. So you can do IHC as in this case, and we can see that they could be linear hyperplasia, a nodular hyperplasia, adenomatoid hyperplasia, and occasionally there is this concept of calling them as dysplasia. So pseudopyloric metaplasia versus antral glands. This is extremely important, especially if the biopsy site is not confirmed. So how do we do that? Because you see, you're trying to give a diagnosis of autoimmune gastritis, saying that these are the changes that one is seeing in the body. Now, provided you are sure that you're not looking at an antral biopsy. So IHC gastrin can help because it suggests that this is that is antrum, and it is not body. So if the gastrin is positive, then you're looking at antral mucosa, and therefore it is unlikely to be AIG. Also, the pseudopyloric glands, they secrete pepsinogen 1 and 2, which will be seen in the corpus, and they have enterochromatin cells, whereas the antral glands only secrete pepsinogen 1. So with that, we'll move on to a few special types of gastritis. There's eosinophilic gastritis, which clearly suggests that there's a high incidence of where there's dense eosinophils. You will see them in the lamina propria within the crypts degranulation, and the number and the distribution is important. More than 30 per high power field is suggested, and you would put out this diagnosis provided that there is no H. pylori or Crohn's disease or anything else. Here, this is another case of celiac disease, where, as you can see, on this part is mild chronic inflammation, but there was a definite, this is a CD3 shows an increase in the T cells, suggesting that this was lymphocytic gastritis, commonly seen with H. pylori and in celiac disease, but occasionally can be seen with Menetrius disease. Collagenous gastritis is also well described. See, GVHD are not common only in the transplant setting, but look out for these crypt apoptotic bodies, which is a clue to the diagnosis. So we'll come to the next part, which is the staging, Olga and Olgam. I think people are becoming more and more aware of it. And this was a staging standard that's developed from the Sydney system. So when we look at this, so two things to remember, atrophy and intestinal metaplasia.
Dr. Paulose, we are near the end of time.
Yeah, I'm also coming to the end. So Olga and Olgam this is a standard biopsy protocol where you have to take biopsies from the antrum as well as the body. And you have a scoring system, and stage three and four gives us a risk for gastric cancer. Similarly, there's the Olgam, intestinal metaplasia. Both of them can be used. So just a few words on the ancillary tests that can be used, which helps to give us the diagnosis. And this was a recent, we had developed an AI tool to detect H. pylori. And I think this would be useful for especially the young novice pathologists who may not be familiar with the very few H. pylori that may be present in the biopsy. So to summarize, it's good to have a pattern-based approach. You should grade the degree of inflammation, always comment on H. pylori, look out for the IM and atrophy, use the Olgam if possible, identify the topography, identify any special types, ancillary tests as and when needed. So to conclude, we as pathologists is very relevant in that multidisciplinary team, so much so that even if you were to come for a conference such as this, they will miss you. So just to let you know, we have a 2-year fellowship at Amrita in GI and liver pathology, and welcome to Kochi whenever you get a chance to come and visit us. Thank you.